So I have the distinct pleasure of interviewing Dr. Toby Gilbert. She is a doctorate in clinical psychology with a specialty in neuropsychology, working for the past 19 years in this field. She also has a master's certified addiction professional since 2006. She also works for Onslow County on 4 different task forces for the opioid epidemic, assisting in helping reduce the opioid addiction rates in the county and statewide. So, Dr. Gilbert, thank you for taking the time out.
Sure. My pleasure.
What we're going to do is we have a few sets of questions that we would like to ask you.
Okay.
Our first question for you is, what are the most noticeable signs or symptoms of opioid addiction for the people you've encountered in your profession?
I think some of the most notable signs are, characteristically wise, it's going to be individuals that are struggling financially, that have a very poor social support system, that have been really been struggling with other addiction issues. Some have other addiction issues like alcohol addiction, or traditionally gambling, or has started using other things like cocaine or crack cocaine, methamphetamine, amphetamines, and have moved over to the opiates. Other individuals that have had chronic pain issues and have inadvertently become addicted to opiates in the form of prescription medications. So those are some of the socioeconomic and characteristic signs that we see from individuals. Some of the actual physical signs and symptoms of the addiction process that we see with them that are suffering from the addiction is we see them sometimes when they're in withdrawal from the substance itself, is we see noticeable tremors. We see them very excitable, very restless, very anxious. They go to great lengths to seek out the type of opioids, whether it's going to be in the form of prescription drugs. So they may go what we call doctor shopping, go to different doctors with different symptoms and seeking out Percocet or Vicodin, other types of opioids. Or that you will find them kind of lingering on in different areas of the city or county that aren't unusual for them to be around, trying to find individuals that they may identify as potential drug dealers and go to certain places that they wouldn't typically go to. They may have profuse sweating, acting like they have the flu because they're in withdrawal, things like that, and really talking a great deal about particularly pain or that they're in need of something medication-wise to help them feel better. So always looking for something to make them feel better because they're feeling so miserable.
Now, when they are taking the medications, what do they look like?
So when they take, if it's a prescription opioid in some respect, what you'll see is they'll start to calm down. They tend to function like everyday people, and that's if they're taking it in a quantity that works for them. So what we might take it for pain conditions, which might be one Percocet, one Vicodin, that's for people that have an addiction issue, really is not going to do a lot for them. That may just be the start of it. They may need to take 3 or 4 pills to get them to a level of functionality. And so once they take those 3 or 4 pills, they're going to act just like you and I. And this is not just individuals that are what the stigma has them as, quote, druggies. These are people of all different socioeconomic status. So you have your professionals, CEOs, lawyers, executive professionals, all the way down to what, could be just somebody walking on the street. So they will function with, half a bottle of Percocet in their system just like we do on a normal day without anything in our systems. So one pill won't work. If they're using heroin in that type of form or snorting it, they're going to look, again, they're going to get this small high for them, but they're also going to look pretty zoned out because the heroin is going to give them a rush, but it's also going to bring them down. So they're going to just feel very calm, very loose, very just chilled out, because it drops their heartbeat, drops their respirations. It makes them feel way too calm, particularly as it enters their bloodstream so quickly. And that's usually, again, through the needles or snorting it.
And when they overdose, what do they look like there?
So when they overdose, it actually, again, it's because of the way that heroin works or the way that opioid works, it reduces your breathing, it's going to reduce your respirations, your heart rate, everything in your central nervous system. So really, they're going to look like they're sleeping. They look like they're dead because they essentially are moving to that particular state. So they look like they're really in a very, very deep sleep, and they're not functioning very well. They're very slow speech. Their eyes are droopy, and they just don't look like they're able to participate in much of anything. And if you come upon them in the house or whatever, they may be laying in a very unusual position in a very unusual room, like laying on the bathroom floor, laying on the kitchen floor, and they're unarousable. They're not really able to get a hold of them to respond to you.
Interesting. Okay. Now, what are some ways to reduce the risk of an addiction and ways to reduce the epidemic itself?
There's a lot of efforts in that respect. That's a really great question because there are a lot of different views on it, and a lot of money from the federal government at this point that's being put out there to do just that, reduce the addiction, reduce the epidemic, or to address the epidemic. And there's so many different views. So right now the efforts are being, and the money is being put towards medication-assisted treatment. So you're looking at using either methadone, Suboxone, Subutex, which is the same thing. So utilizing these medications that are similar in properties to opiates to be able to put the individuals on these doses of medications and be able over time to taper them down so that they don't use heroin or opiates, but to use these alternate methods of medication to help them through withdrawal, because withdrawal from opiates it won't kill you, but it'll make you feel like you want to die because you get so sick when you withdraw from opiates. So the idea is to taper them over the course of a year or so off of opiates through the use of Subutex or methadone, and eventually help them get off of it altogether. So there's a lot of money that goes into medication-assisted treatment. So that's one method. The other idea is to utilize treatment in the form of talk therapy, your typical 12-step programming, or if it's not just 12-step programming, but group therapy with individual therapy and the medication-assisted treatment in the form of either an inpatient treatment or like a intensive outpatient program that they would go to daily. It's called SAIOP, Substance Abuse Intensive Outpatient Program, where they would go every day for 4 to 6 hours and have groups and individual treatment, talk with individuals that are having the same problem. So building kind of a social support system to, over the course of time, to do education, build social networks, a lot of that type of therapy,
now,
adjunctive to address it.
What about Narcan?
Narcan, again, is a part of this whole thing, but it's really a Band-Aid in time, because it doesn't address the addiction and it doesn't address the epidemic. Narcan it's like it's used. People have the wrong idea about Narcan. Narcan is used on the streets by paramedics, first responders, whomever. When somebody is actively overdosed, they can give the Narcan. It can be used through a needle. It can be used through inhalation. It's a nasal through that. But all Narcan does is block the opioid receptor in the brain for a brief period of time, so that the opioid isn't being uptake, if you will, for a bit. And that just brings the person, hopefully, out of their state of unconsciousness back to consciousness. But the problem with Narcan is that people think it reverses the overdose, and the problem is that it doesn't reverse it. It just stops it for a brief period, and the person continues to overdose when the Narcan wears off. So it's like a defibrillator, really, those portable defibrillators that people use in the community. If somebody's having a heart attack, you can go up and you can use that automated defibrillator, and it may get the heart restarted in that moment in time, but it doesn't stop the person from having a heart attack 30 seconds after the defibrillator has gotten their heart going again. Narcan's just a medication form of a defibrillator with somebody that is overdosed. So it's a great thing to get somebody back and to keep them from dying in the moment. But unfortunately, what's happening is people are getting Narcaned in the community, and then they think they're all better. They think they're, hey, I'm good, I'm great, never felt better. And they're being left alone and saying, hey, here's a Narcan kit, or hey, you look good to me, you're making sound decision, and they're being left alone. And then the opiate kicks back in, or they do it, do some more, and they're re-overdosing within an hour or so, and then they're by themselves and they're dead. So we just have to do a lot more education, I think, around Narcan and help people understand it's truly just a Band-Aid.
Understood. Okay. So I know you touched a bit upon this with the first question. Do you see any trends of opioid recovery based on different socioeconomic status, race, gender, family statuses, and how do personality traits play into addiction and the recovery of addiction?
Unfortunately, there's not seen a great deal of recovery at this time amongst any particular SES, gender, class, religion, you name it. It's still, unfortunately, the opioid epidemic is still going in the wrong direction. It's slowed down in the rate that it's going up because of the efforts, but we have not leveled off, and we're not seeing a decrease. What we see is just we're seeing more interventions and more money being allocated to those efforts. So that graph is going up, but we haven't yet hit the decline or the leveling off of the recovery efforts. And that's also because we don't have enough professionals either that understand the addiction process to really work in that capacity, nor in Onslow County do we have enough resources to really address the issue either, where people can go to get that type of help. So there's, and with addiction, there's no discrimination across, it doesn't discriminate who the addicted individual is going to be. It doesn't matter SES, it doesn't matter religion, race, color, creed, color socks you wear that day. It doesn't matter. It's going to hit who it hits and affect who it affects. Where personality traits play in, along with genetics, is the type of personality is, are you a person that, is a go, 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 can't slow down, versus, are you a rigid individual? Are you a more lax individual? Are you a high-stress individual versus a non-stress individual? Because what we know is that individuals that push themselves very hard, need to keep going, tend to ignore their body. They tend to ignore any type of medical issues that they might have. And then eventually their body does break down. And when it gets to that point where they can't function, they all of a sudden need something to help them function. And they want to ignore the pain that they are having to be able to function in their daily life. So they start to take something that helps alleviate the pain. So they do go see a doctor, and unfortunately, sometimes the NSAIDs and the ibuprofen, things like that, aren't really enough to help them. So they get prescribed the hydrocodone or oxycodone, appropriately so. But over time, they start taking it more, and then the addiction process starts, and they start taking more so that they can continue to be functional in their life. So it's an unfortunate event of addiction that occurs with that type of personality traits. People that are pretty lax, pretty chill, that don't really take life as a major stressor, they have great coping mechanisms, they have good social supports, they have people they talk to regularly, they have good hobbies, good coping skills. Those individuals tend to be less at risk for being addicted to the harder drugs, if you will, like heroin, opiates, methamphetamine, things like that. Because if you're content, you're chill, you got good social supports, you really don't have time to be out there, using drugs, because you're already not high strung, you're already involved in your life at a pretty good, pretty healthy level.
Okay. Now, you touched upon the difficulty in recovery. Have you noticed any different types of treatment programs that show different outcomes between age groups, such as seniors, adults, and teens?
Well, again, I think, it all kind of ties back into the same method of treatment. The medication-assisted treatment really has been most popular with the 18 to, I would say, about 55-year-old population, because that's your working group. That's the group that is, has their families and supporting their families, or job, your employed group, if you will. So they're the ones that need to keep going. And medication-assisted treatment is what helps them keep going. Unfortunately, what we've seen is a trend in that individuals that have gone through medication-assisted treatment don't really ever come off of medication-assisted treatment. The idea of it is, we call it MAT, M-A-T, is that over the course of a year, they taper off of this medication so that they are completely off of any opioid-based treatment, and they've built their support systems and so forth and so on. Unfortunately, many treatment centers, the physician's idea is that why take them off of it? Once an addict, always an addict. And they also make money on people coming, because it is generally a private pay. Most insurances don't pay for it. So it is people paying out of pocket for this type of rehab. And because it is generally people that are working, or however they're coming up with the money for it, those agencies or those places that do medication-assisted treatment are making money on doing that type of treatment. So you don't really see people successfully come out of a medication-assisted treatment program ever. But that's not to say they're not successful in their life. They just don't ever really get off of those type of things. So kids, what we see is the adolescent people under the age of 18, that's the toughest group because of the peer, issues, and they don't really see their life beyond 18. They're all about themselves right now. Nothing's going to happen to them. This is just a moment in time, and I live right now. And they don't see themselves 10 years down the road, and their decisions now affecting them later. So they may be successful for a period of time, but it's really hard for them to sustain recovery under the age of 18. And elderly people, we don't see a lot of success because they may be in recovery and doing well, but as they age, they also come to see that many of their peers are dying, have chronic pain, and part of it is, I've lived most of my life, so who cares if I'm an addict? Who cares if I'm using this stuff? I've lived a good life, and I deserve A, B, and C. and my peers are leaving, my family doesn't care about me, I'm just a burden. So who cares if I take an extra 3 or 4 hydrocodone, stuff like that. So, and I'm not saying that's overall, but that's just the treatment trends with those populations. So, so I think, again, what we've always done in treatment has not been overly successful when we talk about the way that we've approached it. I think there has to really be a different thought process in how we reach all of them, everybody in treatment, to really be successful overall.
Now, the next question, it sounds like you answered most of it, to be honest. It says, what do you feel is the most effective medical-based treatment for those who are addicted? And you're telling me that you really don't see much improvement at all?
Not in using medication-assisted treatment. Switching one drug for another, I'm not sure that that's always the best way to go, because much of addiction is psychological. You have the physiological addiction, but you can get people through that withdrawal period of physical addiction fairly quickly, usually, depending on what it is, within a few weeks. But then the rest of the addiction process is psychological, and that becomes the hardest part. But you can't keep giving medication to get somebody through a recovery process if you are trying to deal with the psychological basis of that addiction, because you've got to change a whole lot of things. And how do you change the way a person thinks if you keep giving them meds that is still putting the drug in their body for all intents and purposes? So it's about changing behavior, it's about changing thought processes, and so I agree with using it appropriately over the course of a year and helping them get through, that worst of the worst, but there also has to be an endpoint for that. And at the same time you're doing that medical, the medication-assisted treatment, though, you're talking to them and working with them about changing behavior, changing thoughts, but also giving them other ways to manage, like increasing social support, finding healthier coping, healthier living styles to supplement that. And that's the part that I see is missing, because they're not requiring treatment with the medication-assisted stuff. They're just giving them the drugs, sending them on their way.
So this actually ties into the next question. Is there a specific curriculum or initiative that you feel recovery programs should follow? And is there something that is not standard you think should be standard? So if medications aren't enough, what else can we do?
Yeah. I mean, when Suboxone first came out, the DEA and all that used to require that if you were a Suboxone provider, you had to provide treatment twice a month. And it didn't say how that or what that treatment looked like. You just had to provide something else besides the meds. Well, it kind of took off on them because they used to come out and monitor those Suboxone providers to make sure that treatment was occurring. But because so many providers then became the Suboxone and methadone providers, there was no way in the world they could keep up and make an audit and make sure that was occurring. So providers were like, I'm not going to do it, don't have the resources, so they stopped. So, I think that something that needs to happen is that I think these programs really have to put more emphasis on the social aspect of treatment versus the medication. Yes, here's the medication, but let's talk about what else has to happen. Let's ensure this is happening and really put a very strong environment in around that component if they want this to be successful. Because as long as you just keep focusing on the drugs and make that the main component, why would they not take that behavior and continue it when they leave that facility and make that their main thing when they go back into their everyday life? Mm-hmm. It's still their main focus. So if you make social support and everything else that main focus, then it can transfer over into their everyday life, because it's their everyday life if they're in treatment doing the same thing.
Okay. And to be honest, you addressed most of the next question as well. It says, how can we keep those who suffer from substance abuse involved in the program? So it sounds like social support is the key there. And then it asks about success rates, and that sounds like it's been pretty poor. So do you have any other suggestions or opinions for development of a community-based opioid treatment program?
I'm sorry, can you repeat that? Sorry.
If you had your ideal program, what would your ideal program look like?
Oh, goodness.
You have
ideal
unlimited resources, unlimited people.
I think, gosh, I had that opportunity. I think it would be a progressive. It would start with like an inpatient program that would then progress to outpatient over time, and just so that you could get the detox component in there, and then it would start with, it would have the medication assisted, but starting with detox, and during that detox, it would just start from day one, with the expectations and such, and really address, okay, here's the focus, here's the idea with regard to, we're going, yes, we're going to do medication assisted treatment. However, we're also going to do this as, we're going to talk about changing your thinking, which changes your behavior, or changing your behavior, which is going to change your thinking. And it's going to include building and identifying, the positive social supports in your life. How to build healthy living style, because it is a lifestyle change, and healthy coping. But a lot of it, I think, not only is changing the way you think about addiction, but it's also changing the language for that individual about addiction. Because there is such a negative stigma around it, and a lot of it is sometimes the way we talk about it and as a community, but also how that individual that is suffering with the addiction process labels it and tells them and talks to themselves about the addiction process and about themselves and their self-concept. So I think the whole thing for me would be more about building a village around themselves and how they build it for them. Because if I build it for them, it's not important to them. So it's about giving them the tools to build it for themselves and helping them do that through beginning with detox, an inpatient stay, and then building it through the intensive outpatient and doing a step-down program over the course of 6 months to a year, putting all those things in play and having peer support specialists and people with lived experience, but doing it through, combination of treatment methods, but really changing their language all the way through that, which begins the process of changing the way you think and the way you act.
Dr. Gilbert, that was some fantastic interview. Thank you so much for taking the time to educate us and help us through this subject. We know it's a difficult one that obviously everyone's trying to work together to figure out an answer. Sounds like there isn't a great answer, but hopefully we're starting to see the trends decrease soon. Well, again, thank you so much.
My pleasure, and best of luck. I mean, I'm glad you guys picked this as a topic, because it is very much one that needs expansion on. So I wish you all the best.
Wonderful. Thank you so much.
You're welcome.